Um, well, if there's no other question, because of time, I think we better proceed to our next speaker. Our next speaker is Dr. Hariz. He's in the university Malaysia, and he's very interested in training of vascular surgeons, and also he wrote many articles and published many articles. His interest is in teaching, so he's going to talk to us about lower limb intervention. Okay, Haris, over to you.
Okay, thank you, BK. So I'm going to talk about tri-wedge in lower limb intervention. So just to make a disclosure, I mean, I don't have that many experience using this device in the lower limb because one is because it's fairly new in the market. Two is because of the COVID pandemic, our cases fairly low because most of the cases, because of the high number of COVID in my hospital, we have to send them out. So I think for this past few months, I only managed to collect maybe two, and just now we use another one. So yeah, not many actually. So I just want to share my experience, and then maybe we can discuss about it. So just a bit of background. I think I'm not sure about in China, but in Malaysia, I think we see quite a number of this PAD patient, especially CLTI, because we have a quite high number of diabetes, right? And we have guidelines already in terms of management of this condition, basically the global vascular guideline. And even nowadays, we get a lot of devices in the market, namely, stand, I mean, drug-eluting stents, DCBs, even some crossing device and things like that. Okay. However, we still have limitation. I mean, we have recoil problem. I mean, you guys, the previous speakers talk about recoil problem, even in AVF, I mean, even standard OBA, I mean, especially in peripheral realms, we tend to use stents, but if we use stents, we know that the instant restenosis is fairly high, and then you are forced to use drug elution technology, and then the problem with drug elution, it won't really work in a heavily calcified vessel. So this in this situation, it calls for something more, advanced. I mean, we have atherectomy device, and nowadays I think we are using more and more scoring balloon to basically to modify the plug. And of course, we have other things like mechanical forces, which stent design is fairly important. And also, after we did the procedure, we need to monitor them, right? Okay, so moving on to scoring balloon. So in terms of the peripheral, I mean, lower limb realms, I think there's a few papers already there. I mean, this is the paper that I've taken, quite a recent paper in 2020 from the, Japanese group, Kazunori. So according to them, I mean, based on about 400 cases that they've done, I mean, their conclusion was scoring balloon effectively restore the acute lumen gain and prevent, and it's actually associated with a better primary patency at 18 months. So the result is fairly good. And there's also another result, a long-term result by this group. Basically, is a different brand actually, but also a scoring balloon. So basically, they have about 400 cases as well where they randomize. So after 2 years, as you can see here, the result, the scoring balloon fares better in terms of the freedom from TLR. Okay, so this talk is about tri-wedge. Tri-wedge is a fairly new scoring balloons. I mean, probably you already know the indication. Basically, this is what the IFUs of the tri-wedge says. So it can be used for stenotic lesion in the iliac, femoral, iliofemoral, and also popliteal, and even the renal artery, which I haven't actually used yet. Bear in mind that it's not recommended to do, I mean, for for the tibial vessel because, of the size issue. Okay. So the main thing is the balloon length. As you can see here, is quite a short balloon. The shaft length, I just want to highlight this because in the lower limb, sometimes we have to puncture from contralateral, so we need a fairly long shaft. So for tri-wedge, I think the one that is available here is only up to 90 centimeters. Okay, so I mean, if patient is fairly tall, so I mean, if you go crossover, you might not be able to reach the popliteal. So please remember that. Okay, so I mean, this is all been said before. I think you all should know about the indicators and in terms of the scoring element. I think they have this triple wires, and it's not just rounded wires; it's actually triangulated. And but I mean, if you put your finger there, you won't hurt yourself because it's fairly blunt. But you can still, when it is effaced, you will still, you know, cut the vessel a bit. Right. So you got your nominal pressure and rated burst as usual. I think normally it can go up to 20 rated bursts. Okay. So according to the company, I think the design advantage is basically allow accurate positioning, minimal slippage, watermelon seating, which I actually experienced. And it creates the focal stress to facilitate lock plug modification under low pressure. And patient doesn't really experience that much pain even on the very high pressure. Okay. And also it provides excellent flexibility and trackability even in tortuous vessel, but most of the time I think for a lower limb is fairly quite straight. It's not really that tortuous. Okay, so this is just some pictures of tri-wedge in action in vivo, in vitro. So as you can see, it scores like that compared to the others. And you get this linear scoring compared to angioscope, which is more spiral. And as you can see, the pressure that is required to score is much less compared to a normal PTA without scoring element. And this, as I think Vicky Lim already mentioned just now, that even Sarah mentioned just now, that it can go all the way up to 20 without any problem, and it can actually create a better outcome compared to the other scoring balloon. Okay, and the other thing that is unique about this device is, as you can see, the tip is fairly tapered compared to the other devices. So you can actually slide the what do you call it, this device through the very stenotic segment quite easily. All right. And when it bend, basically it bend like that, so it doesn't really damage the balloon compared to other devices, right? Okay, so it got the smallest tip in the market, and normally when we put it in, the scoring element is fairly protected. Okay, and then it's quite competitive in the sense that it have various sizes for us to be used, except for lower limb, where I find if they can actually provide a longer shaft, it would be good. So please, the company, please take note. Okay, BrosMed. Okay, yeah, basically I think I've mentioned this before in terms of the rated pressure. Okay, and then this also I mentioned before, we don't need to go through this. This is just comparative to the cutting balloon, where it has the blade. And those who are familiar with the basket track, the wire, the configuration is like that. There's two scoring elements. So there is an operating instruction for this. As mentioned just now by the previous speakers, you have to inflate the balloon fairly slowly, so that it will open up nicely and unfold. When the balloon unfold, and then the scoring element will just, expand slowly and then get into the vessel and score it. So don't inflate too fast. So take your time, just inflate slowly, and then it should work. Okay, enough about that. So I think I just share my case. There's only 2 cases, like I mentioned just now, not much cases recently. So I will tell you what we did wrong and then what we did okay. So the first case, so 51 years old Malay female, as usual, multiple comorbidities, diabetes, hypertension, end-stage renal failure. So we know that the vessel is going to be calcified. Right, present with the right, third, and fifth toe gangrene. He had a amputation done on the on that toe actually. Okay, previous right, third to fifth toe re-amputation 2016. Incidental finding a poor healing left foot ulcer with dry gangrene of first and fourth toe during follow-up because he had a previous recent post-ABF transposition. And when we check, of course, the pulse is not palpable and the APSI is fairly low. So this is the run. So we decided because the femoral is fairly strong, and then when we scan, there's no origin SFA disease. So antegrade puncture was performed under ultrasound guided, 6 French sheath inserted. So the flow is fairly okay, except as you can see here, distal SFA and popliteal, there is a lesion there. Probably about 70 to 90% stenosis. Just a short segment. So this is below the knee. As you can see, the origin of the TP trunk and also the anterior tibial is diseased as well, stenotic. But distally, you can see the runoff is fairly okay. And this is the foot. So this is probably one of our earlier tri-wedge cases. So we selected a relatively quite straightforward case. So as you can see, the wire, our 014 wire just sailed through without any problem. We don't need to go suboptimal or whatever, or retrograde puncture. So after that, we just employ the use of, in this patient, we use a tri-wedge 5 mm. So we just balloon it in sequential manner. Basically, we just balloon maybe about 30 seconds for each segment because it will take a long time. As you can see, we just take our time in terms of inflation. The balloon effaced nicely in the video. And then after that, we just carry on and balloon the whole SFA. So that's the angiogram after the tri-wedge. So there is a good flow with minimal dissection there, non-flow limiting. So we thought that it's all right. So we just carry on ballooning. And then after that, we just use a longer balloon to tag whatever flap that is there. And then this, I mean, the ballooning is just a POBA. I mean, at this stage, we decided not to use any DCB because patient's vessel is heavily calcified. So we just use a prolonged ballooning, but at this stage, the pressure is fairly low because we know that, as you can see, I mean, we already used the tri-wedge. So the pressure that required to actually efface the whatever plug that's there is lower than required. So this is the run. So as you can see, the run is fairly good, and very minimal recall or yeah. Okay. So after we improve the flow, as you can see, even the flow down at the tibial also is fairly good, and you can start to see this peroneal vessel, which was not there on the initial run. Okay, so so for that patient, I think post-operatively we can get a strong BP and TTA pulse. ABSI improved to 0.8, and then after that we did the re-amputation for the first and fourth toe, and then the wound healed fairly well, and we discharged the patient with dual antiplatelet. Okay, second case, a bit more interesting, which I think I've learned something myself as well of what not to do. Okay, 63 years old Chinese female, of course, multiple comorbidities, diabetes, high blood pressure, atrial fibrillation. So you wonder there's probably something else happening because patient got atrial fibrillation. Came in with a poor healing anterior shin ulcer for 1 month and also this necrotic patch at the lateral heel and associated with rest pain. She claimed not able to walk, but otherwise the foot looks fairly, pink, not really like dusty and things like that. So clinically, the PT and DP of course not palpable. With the monophasic signal, ABSI is fairly bad, less than 0.5. So this is CT scan. Okay, so as you can see, the aortoiliac segment fairly looks okay, and then the lesion actually starts at the origin of the SFA, and is quite calcified there with plaque, and as you can see, there's a multiple stenosis, distal SFA, popliteal, all the way down. There's also a tibial disease as well. But having said that, the anterior tibial is fairly okay down to the foot. All right. So decided to go from crossover puncture. Okay. So this one, my trainee, my fellow did it, Susan. So so this was what we found. So as you can see here, I mean, because she called me halfway through the case. So as you can see the run here, there's a abrupt cessation of flow at the proximal SFA. I mean, it corresponds to the finding on the CT scan, and then she managed to pass the wire through relatively straightforward, and then did some run within that occluded segment. As you can see, there is this reconstitution of flow in the mid SFA. And distal SFA, the flow was fairly okay with multiple stenosis, but not very bad. And then the behind me and below me popliteal also not too bad. And with fairly okay runoff. I mean, there's a anterior tibial and peroneal there. So at this juncture, I mean, it did not occur to me at that point that there's probably some element of thrombosis as well. So we decided to score this lesion because it was also calcified. So we use Sporflex 5 mm and just score that area. So we scored the whole length. And this was what we got. As you can see here, it was not good at all. I mean, you see a lot of collateral there. I mean, at this juncture, I mean, it's still not occurred to us that there is still some element of clot inside there. So we thought that it could be just recall or things like that. There is good reconstitution distally. So we decided, okay, let's just balloon it with a long balloon, prolong it a bit, maybe 3 minutes. And okay, let's see. Okay, so again we'll see this. So what is actually happening here? So at this juncture, I think we decide to stand basically. So we put a stand, quite a long one, Everflex. As you can see, it's quite calcified here. And even you can see the calcium track on the DSA. So we managed to get fairly okay lumen after the prolonged ballooning, but it's still not enough. So that's why we decided to put a long stand here. But when we put in, because the lesion was not prepped properly and maybe there is some element of thrombosis, so the stand did not expand fully. And after the ballooning, it expanded. But okay, so the same thing happened. You see, there's no flow within the stand. So there is something else happening. So only at this stage, I think we thought, okay, this could be probably organized thrombus sitting there, and then it doesn't really work with the stand. So even with the ballooning and As you can see here, we balloon again and again, and it still doesn't achieve quite a good lumen within the stent itself. So what we did was, okay, so we use this device. I mean, it's basically a long sheath. So I really like to use this this sheath. It's called Fortress sheath. Normally I use 6 French. So what happened was we just suck out whatever clot that is possibly there, normally over the wire. So the good thing about this sheath is you can actually disconnect the valve, and then you can actually suck it. And then when you achieve a good backflow again, and then you can introduce your wire again. So, I mean, you will lose your wires during this procedure, but most of the time, I mean, if it's just a clot, you should be able to cross again the lesion. So this is quite handy to have in this kind of situation. Other than that, maybe, I mean, other more commercially available device like Penumbra and etc. I think, but that can be quite costly. Right, so after we did that, so we managed to get this kind of flow within the within the stent. In fact, we actually extended the stent all the way just above the profunda. As you can see here, the profunda, there is some clot sitting there, just proximal, but there is still flow inside the profunda. Distally, we managed to get this flow. As you can see, it's not optimal. So at this juncture, we decided to use this catheter-directed thrombolysis. So we park a catheter there. We don't have the fountain catheter, which is commercially available. I mean, one of it because of the cost issue. So what happened is we just use a standard 5-French catheter, and then just make multiple hole at the side using a small needle. So that's what we did. To save cost. So we run it over 48 hours, and then we repeat the run. As you can see, it's very nice there. So it managed to dissolve whatever clot that is left. So it looks very nice, and the pulse actually came back, and we managed to discharge the patient. Okay, so this is how it looks like. So the patient was discharged fairly well with the aspirin and rivaroxaban. We give a therapeutic dose for this one. And surprisingly, I think the wound is healing very well after the debridement. Okay, so I think that's about it that I want to share. So my take-home message, I mean, for these 2 cases, I think scoring balloon is highly effective in heavily calcified vessel. Having said that, I think one must be aware, especially if you want to do this, make sure there's no presence of thrombus. Okay, and if all endovascular surgeon or interventionists must know how to troubleshoot if this kind of thing happen, you know. You need to have a backup. Try not to leave anything behind, because eyesight is a major headache, and I think tri-wedge might be, I mean, a useful tool, and might be a paradigm shift in terms of the plug modification, and I most likely will use it more and more often with the iGers as well. Then we can see actually the good things about it. So with that, Shishini.
Thank you, Hariz. Thank you. Very nice talk. Anyone has any questions? Any questions?
Hariz, do you find that when the shape of the balloon takes place very fast, maybe there was a soft thrombus there or something when you inflated? Did you notice anything out of the ordinary? Was the balloon not inflating fast enough, or was it inflating too fast?
Yeah, I think I see that, and also I've seen. I mean, there's also an element of stenosis there as well along that calcified area. But I agree with you. I mean, the balloon inflation, I mean, you can see the effacement fairly fast rather than you see the dog bone effect kind of thing. So that should have actually triggered me that there is element of thrombosis there as well. What would you have done? Differently. If you see these kind of cases.
Sorry, if you're asking me, I would look at looking at the CT scan itself, for the second case, right? You're talking about the second
case.
We saw it was suspicious of a thrombus because it was a sudden occlusion and there was nothing, and then suddenly you start seeing plaques down there. Given the history of atrial fibrillation on rivaroxaban, I think the clue would have been that. But also, I think when we are traversing the wire, it may have shown that it was easy to traverse, maybe a bit too easy. So that might have given us an idea that it was actually a soft thrombus there and thing. But you never know. I got caught out also a few times before like this as well. So it's great you managed to bail yourself out. Good job.
Thanks.
Yeah, well done.
Sometimes it's hard if you get other people doing the case, starting it, and then you come out to to bail them out. So it's getting more and more often nowadays because we got trainees and we cannot be there most of the time sometimes, So that's happening now. But in terms of that, I've also learned something, how to do more troubleshooting. So that's good for me as well.
Okay. Has anyone got anything else to add? I think we are actually running well over time. So, Professor Jing, you have anything to add? Anything to say?
没有垃圾，是这样，我简单的。
Nothing. So I'll say a few words. Then we will wrap up. Okay. Then we will conclude the day.
Yeah.
Okay. So I'm so pleased to use some time in this afternoon to talk about the guide wire balloon scoring balloon to exchange our experiences. I'm especially happy that we could communicate with our friend from Malaysia. We know due to COVID-19 pandemic, many offline meetings cannot be convened. So many domestic and international meetings are in the virtual form. So I'm really looking forward to have face-to-face communication in the future. So today we've been talking about the guide wire balloon in terms of the vessel pathway, especially the AVF, how to use it. So I'm so happy to have this opportunity to have an introduction to the Malaysian colleagues. So in China, this balloon hasn't been approved yet. According to the China FDA's requirements, a pre-marketing clinical study is needed. Therefore, in China, we have been conducting in using the guide wire balloon in the AVF. It's a randomized control trial. So I'm the PI. Just now, Professor Wang Pei, and he is one of the centers. In total, we have 8 centers for this study. This study has been concluded not long ago. So the final statistical results are not available yet. At the very beginning, when we knew the design, after we understood the design and the function of this balloon, we focus on the rigid, hard to dilate stenosis lesion. For those lesions, we expect this balloon could have a better performance. Therefore, we are focusing on the technical success rate, just like you mentioned. For all cases, at the moment of procedure, could I open a lesion which cannot be opened by other common balloons? That is something we are looking forward. But our government requires a relatively longer follow-up, so we extend our trial. So we designed a 6-month follow-up period. Generally speaking, this balloon, according to our study, and in total 160 RCT studies cases, Up to now, in each center, we all feel that in terms of the technical success rate, it's totally okay comparing with conventional high pressure balloon. It's similar, and there's an interesting point. I could use a relatively lower pressure to open a relatively rigid stenosis, so will the patient suffer from less pain? So actually, at the very beginning of the design of the trial, I designed a pain scale. I want to quantitatively evaluate the pain. The subjective feeling of the patient is that in the trial arms, the patient feeling seems to be better than the control arm, but there's, because I use a 10-point scale, but there's no statistical difference. But in terms of the technical success rate, it is exactly as the one of the conventional high pressure balloon. So I'm so happy that just now we had a warm discussion. That would be the approach selection for the transanastomosis. So with a large angle, how the balloon could be manipulated. So I do believe with your discussion, so I could feel that you are all very experienced in using the balloon for the AVF. And in China, most of the most anastomosis would be to end-to-side anastomosis. And most of the anastomosis, their anterior wall is relatively at the distal position. So we've encountered many interesting topics, like the angle is large and the entering of the balloon is difficult, especially for the transanastomosis lesion. When you open the balloon, we have some concerns we could understand, because we all know for the our autologous AVF, the features would be it's rigid. Therefore, we use high pressure, even ultra high pressure, even the cutting balloon. However, the ultra high pressure balloon and cutting balloon, they behave poorly in terms of turning over. So they have a thicker wall. So I think the guide wire balloon has solved this issue. So it has its advantages for passing the large vessel, and the experience you shared has proved it. I think that's the advantage of this balloon. Just now, some colleagues mentioned, like for some C-shape lesion, like 180 turnover. So actually, a feature of this balloon would be the guide wire of this balloon is not fixed to the balloon wall. The guide wire is free, not like the blade of the cutting balloon. They are fixed. So when you bend this balloon to a large angle, the guide wire will migrate. It's not fixed to the surface of the balloon. So that's something we consider as advantages. At the turn, Professor Wang and our friends from Malaysia, you all showed the traceability and the dilatation function are both good. So I think in the future, there are several points we need to focus. Technical success is not a problem, and the success in the caster room, no problem. What about the long-term results? Just now, some colleagues mentioned, should we combine it with the DCB, drug coating balloon? I think that's a interesting topic as well. The DCB, it's very controversial in this field. Different trial results are different. Some say some results are positive, some results are negative. So I'm really looking forward that more and more colleagues could focus on this field. So we could explore in terms of the long-term results. The guide wire balloon or the DCB may behave better. So that's our focus as well. In the future, there are few issues, because we used to have DCB trial in China. So we had questions. So which lesion are the candidate for the DCB? For primary, for the first-time lesion, or for a lesion which cannot be solved by conventional balloon? So this balloon would be the second or the third balloon, or the exposed ones. Like for the cases you just mentioned, the patient received the dilatation but restenosis, then what option we should choose? Should we choose a DCB or a guide wire balloon, or we repeatedly use the high pressure balloon to dilate? So different scholars have different opinions. So I'm looking forward that we could have these questions will be answered by very good trials. But at this point, we have no international consensus, at least in the international vascular intervention consensus, there's no agreement. So we need further discussion would be needed. And today we had a very good discussion, and we are all colleagues. So we have a lot of shared topics to communicate. So I'm really looking forward in the future we could meet face to face and to have further and deeper and profound discussion. And I'm looking forward that we could conquer the COVID-19 pandemic. So everything will be returned to normal. So that's my summary. So thank you again. Thank you, friends from Malaysia. Thank you for sparing some time from your schedule to discuss with Chinese colleagues. We did learn something. We should be healthy. I think that's all. We could call it a day. So
Yes.
I would like to declare that let's complete today's meeting. We are looking forward in the future. Okay, goodbye. See you. Bye-bye.
Thank you.